Let's begin by establishing a clear clinical definition of Tuberous Sclerosis Complex, or TSC. At its core, TSC is a multisystem autosomal dominant neurocutaneous syndrome. The defining pathological feature of this condition is the development of benign tumors known as hamartomas. While these growths are non-malignant, they are widespread and can appear in various organs throughout the body. To meet the clinical definition, we specifically look for these hamartomatous involvements in several key areas, most notably the brain and the skin, which is why we classify it as a neurocutaneous disorder. However, the multi-system nature of the syndrome means we also frequently see involvement in the kidneys, the heart, and the lungs. Understanding this fundamental framework, a genetic predisposition to benign hamartomatous tumor growth across these specific organ systems, is the essential starting point for recognizing the clinical breadth of this syndrome.
Now, let's look at the etiology and pathophysiology of tuberous sclerosis complex. TSC is fundamentally a genetic disorder caused by mutations in either the TSC1 gene on chromosome 9q34, encoding the protein Hamartin, or the TSC2 gene on 16p13.3, which encodes Tuberin. Regarding inheritance, while it is an autosomal dominant disorder, that only accounts for 20% of cases. The remaining 80% result from sporadic de novo mutations. Pathophysiologically, Hamartin and Tuberin form a critical intracellular complex that functions as a negative regulator of the mechanistic target of rapamycin, or mTOR, pathway. A loss-of-function mutation in either gene essentially removes this physiological break, leading to the constitutive activation of mTOR complex 1. This unchecked signaling drives the uncontrolled cell growth and proliferation that characterizes the widespread formation of hamartomas across multiple organ systems.
Moving to the clinical diagnosis, tuberous sclerosis complex presents as a multisystem disorder. Dermatologically, we look for ash leaf hypomelanotic macules, leathery Shagreen patches, facial angiofibromas across the malar region, and periungual conin tumors. Neurologically, epilepsy is nearly universal, affecting 80 to 90% of patients, often manifesting as infantile spasms or West syndrome. Key structural findings include cortical tubers, subependymal nodules, and SEGAs. Renally, we see angiomyolipomas with a risk of hemorrhage, alongside cysts and an increased risk of renal cell carcinoma. Pulmonary involvement, specifically lymphangioliomyomatosis, or LAM, primarily affects adult females presenting with dyspnea or pneumothorax. Don't overlook the heart. Cardiac rhabdomyomas are often detected prenatally, but frequently regress spontaneously. Finally, ocular examination may reveal retinal hamartomas, commonly known as mulberry lesions. Recognizing this constellation of features across these organ systems is critical for securing a clinical diagnosis.
Now, let's look at how we clinically confirm a diagnosis of tuberous sclerosis complex using the 2012 International Consensus Group criteria. We categorize clinical diagnoses as either definite or possible based on the presence of major and minor features. To reach a definite diagnosis, a patient must exhibit at least 2 major features, or 1 major feature paired with 2 or more minor features. If we identify only 1 major feature, or 2 or more minor features alone, we categorize this as a possible diagnosis. Crucially, the criteria also provide a molecular pathway. The identification of a known pathogenic mutation in either the TSC1 or TSC2 gene is independently sufficient for a diagnosis, regardless of the clinical findings. This dual framework allows us to confirm TSC through both phenotypic observation and genetic evidence, ensuring a robust diagnostic standard across the clinical spectrum.
Moving to investigations, our diagnostic approach must be multisystemic. Our first-line imaging begins with an MRI of the brain to identify hallmark lesions, cortical tubers, subependymal nodules, and SEGAs. Simultaneously, we use ultrasound or CT of the abdomen to screen for renal angiomyolipomas and cysts. A thorough dermatological exam is mandatory, utilizing a Woods lamp to visualize characteristic hypopigmented ash leaf spots. While these clinical findings are suggestive, genetic testing for TSC1 and TSC2 mutations remains our gold standard for a definitive diagnosis. Supporting tests are tailored to the patient's presentation. We use EEG if seizures are suspected, specifically looking for classic hips arrhythmia. In infants, an echocardiogram is necessary to detect cardiac rhabdomyomas, whereas in adult females, we utilize high-resolution chest CT to screen for lymphangioleukomyomatosis, or LAM. Finally, an ophthalmological exam, including fundoscopy, is required to identify retinal lesions, completing our comprehensive assessment.
Management of tuberous sclerosis complex is fundamentally multidisciplinary, focusing on symptom control, regular surveillance, and targeted molecular therapy. Neurologically, vigabatrin is our first-line choice for infantile spasms. For SEGAs and renal angiomyolipomas unsuitable for surgery, we use mTOR inhibitors like everolimus or sirolimus. However, if an enlarging SEGA causes obstructive hydrocephalus, neurosurgical intervention is necessary. Regarding renal care, asymptomatic angiomyolipomas exceeding 4 centimeters may require prophylactic selective embolization to prevent life-threatening hemorrhage. For dermatological manifestations, such as facial angiofibromas, we utilize topical rapamycin or laser therapy. Additionally, sirolimus is indicated for patients with declining lung function due to LAM. Finally, you must recognize 2 critical emergencies. Acute flank pain or hematuria suggests a ruptured angiomyolipoma, known as Wunderlich syndrome, while sudden onset headache or vomiting indicates obstructive hydrocephalus from a SEGA. Both require immediate clinical action.
Moving on to the MRCP high-yield pearls for tuberous sclerosis. First, remember Vogt's triad: epilepsy, intellectual disability, and adenoma sebaceum. Crucially, this classic triad is actually present in fewer than 30% of cases, so don't rely on it for diagnosis. Regarding management, vigabatrin is the drug of choice for infantile spasms in TSC patients. However, you must monitor these patients closely for permanent visual field constriction. From a genetic perspective, the TSC2 and PKD1 genes are adjacent on chromosome 16. A contiguous gene syndrome involving both can lead to severe, early-onset polycystic kidney disease. On examination, look for Shagreen patches, most commonly found in the lumbosacral region, and use a Wood's lamp to visualize subtle ash leaf spots. Finally, a unique clinical feature. While most hamartomas in TSC persist, cardiac rhabdomyomas are notable because they often regress spontaneously with age.
And that brings us to the end of today's session. I hope this has been a valuable and clear overview. To truly consolidate this knowledge, I encourage you to take the next step. Visit our online platform at MRCPELITE.com. There, you can create a free account instantly. You will find a structured slideshow summarizing today's topic, followed by 2 dedicated self-assessment tests. One for MRCP Part 1 and another for MRCP Part 2. Each containing 20 focused questions. Take these tests to actively engage with the material. The platform will provide you with an immediate score and, most importantly, detailed, illustrated explanations for every answer, helping you fix the information firmly in your mind. To supercharge your preparation, consider upgrading to a pro user subscription. This unlocks powerful tools, unlimited disease-specific search queries, unlimited access to high-yield exam pearls, unlimited interactive flashcards, and most critically for your exam readiness, full exam board access with 50 question banks for every MRCP subject, and realistic mock exam simulations for both Paper 1 and Paper 2 that closely mirror the actual exam environment. For a limited time, we are running an exclusive offer. Gain all these pro benefits for just $50 for a full year. A significant saving from the standard price of $250. So, head to MRCPELITE.com now. Start with your free account, test yourself, and explore how the Pro upgrade can transform your revision journey. Thank you for your time and all the very best for your studies.